Hello, everyone. Welcome to our journal club. This is our first journal club and third event as part of knowledge translation in neurophysiotherapy. So today we have with us Ms. Nidhi Khokhar, a postgraduate physiotherapist who has recently completed her MPT, and she's a clinician too. And currently, today she's going to present an article, and she's going to apprise the validity of that article in context to a clinical environment, how a clinical decision is made in context to a particular patient management, and how evidence is used in its implementation, right? Okay, so now it's Ms. Nidhi will take over. Nidhi?
Yes, sir.
Yes, you
Hello,
can start.
everyone. Good morning. Good morning, everyone. Thank you, sir, for the introduction, and thank you for inviting me for this discussion. Today we are going to discuss an journal club and critically appraise an article, which is an pilot randomized control trial on the community-based ambulation training in stroke patients. Is it necessary to critically appraise, why it is important to critically appraise an article? The whole purpose of the series of this webinar is implementing evidence into the practice. And when we talk about implementing evidence into the practice, it is not just believing everything what is being said into the literature. You have to read the literature, you have to critically think what is being said, and it is also important when you apply this evidence into your practice, uh, correlate your finding with the research results. And it is not a fundamentally right that giving a treatment which does not have evidence, or it is also not the fundamentally right to give a treatment which is suggested in the literature and not thinking or critically thinking about it. So suppose you are having one patient in your clinic who is 50-year-old female, and she had stroke 6 months ago. Until now, she have reached the FSC level 4, means she is able to walk independently in on an uneven on a level surface. She is able to walk independently inside her home, but she faces the difficulty when she had to walk on an uneven surface or during stair climbing. Right now, her goal is that she wanted to go to the grocery shop and she wants to go to the temple. Now, you must be thinking that what treatment should you give which could help this patient in achieving her goal. And the treatment you are giving in your clinical setup, is it sufficient for this patient? Should you give an goal directed ambulation training to this patient? And you think about searching the evidence. Does evidence support the goal directed ambulation training or not? So you decided to search for an evidence. But the first step in evidence searching is that you must have a question which you are seeking for the answer. The question must include a participant, a treatment which you wanted to see its effectiveness, a comparison treatment, and an outcome which you are expecting. So here I have formulated this question for our patient which we are treating, is that is goal directed varying ambulation training better than routine physiotherapy intervention in improving community ambulation stroke patient? Here we wanted to see the effect of goal directed ambulation training. We wanted to see that is it better than our routine physiotherapy or not, and we are expecting improvement in community ambulation status. The next step in evidence searching is that you look for the evidence, and all as we all know that the best available highest level of evidence is the systematic review, because a systematic review is the filtered information. They have done your job of critically appraising all the randomized control trial, and they are giving the summary. But in case where the systematic review is not available, or systematic review is not answering question what you are asking, then you go for the randomized control trial, because it is the second most highest level of evidence, because the design of a randomized control trial is such that it minimizes the risk of error, but there is always a window of an error, and that is why you will not just come to the jump to the conclusion by reading the conclusion or the result of the article. You must you must see that how they have conducted, what outcomes they have measured, and what results they got. What results they got, not the result they have reported, but what results they have got. We will look into that. And we all know that it is quite difficult for a clinician to go through the article and critically appraising it. So we have tried here to simplify this process of appraising. So today, the article which we are going to appraise is effectiveness of community-based ambulation training for walking function in post-stroke hemiparesis. It is an randomized controlled pilot trial. This is the introduction, that in this article they have targeted population was a stroke patient. In the intervention, they have given the functional training based on Bobath approach. In addition to that, community based ambulation training, they have compared it with the functional training, and they have measured the gait speed, endurance, balance confidence, and walking ability in indoor as well as the outdoor. The objective of this study was to investigate the effect of functional ambulation training performed in a real community environment for patients with post-stroke hemiparesis. The objective of the study is matching with the questionnaire. This study is wanted to see the effect of functional ambulation training which is performed in the real environment. It is an goal-directed ambulation training and in the stroke patient. So let's see how they have conducted this research. They have included the patient who are having stroke, and the stroke duration was 6 months to 5 years. So they have included the chronic stroke patient. They have included patient whose gait speed is less than 0.7 meter per second, and they have given reason that this gait speed is considered as an unsafe community ambulation. So right now the patient they have included is not safe for the community ambulation. They are going to give the training, and then they will see what improvement in this patient are there. The patient who does not have any auditory or visual deficit, patient who does not have an orthopedic or cardiovascular condition, and patient who does not have an cognitive impairment. When you refer any article in the third segment, you will see that whether the allocation was concealed or not, whether the patient, the therapist, and assessor were blinded or not, and whether there was any dropout or not. You will look for the dropout because you will look for the dropout to see that the dropout is because of the adverse event or some other reason, and patients are not completing the trial. Here in this study, the allocation was blinded. Patients were given an envelope with 2 cards, and they have to pick one card, and on the basis of that, 14 patients were included into the experimental group and 13 patients were included into the control group. And at the end of the trial, there was one dropout from both the group. And at the end of the trial, there was 13 patients into the experimental group and 12 patients into the control group. In this study, the therapists were not, only the assessor was blinded. We are looking for blinding because it suggests that there are risk of bias, and we will look in this aspect of bias when in the critic part. So in the control group, they gave the functional training based on the Bobath. They have given the sit to stand. They have given the therapist guided movement of the trunk and the lower limb to simulate the walking pattern, forward and backward stepping of affected extremity as well as the non-affected extremity, and stair climbing activities. In the experimental group, they have given this functional training. In addition to that, 1 hour session of community-based ambulation training. The dosage for this training was 3 times per week and gave for the 4 weeks. So total 12 sessions of this training was given to the patients. And in this 4-week cognitive ambulation training, they have taken the patient out into the real community, and they have tried to increase the environmental demand as patient progresses. In the first week, they have taken the patient, make the patient walk in an 150-meter pathway just outside the hospital on an even surface or on a slow rise stairs. In the second week, the pathway was of 200-meter, which includes the uneven ground and the pavement of public space. In third week, they have make the patient walk an 300-meter path, which include the slow slope pedestrian crossing or pavement with the obstacle. And into the fourth week, they increase the demand. They take the patient into the shopping center where they have to climb the stairs, they have to push the trolley, and all those things. This seems very interesting that they have taken patients into the community to improve patients' community ambulation. Let's see how what they have measured. I would like to give the brief introduction about outcome measures they have measured here. That they have measured the gait speed and endurance. Gait speed using 10-meter walk test, endurance using 6-minute walk test. I hope you all guys are familiar with these both scales, right? They have measured the community walk test. In this test, they have taken the patient, make them walk on a 300-meter path. The path was different than the in which they have taken the training to minimize the learning effect. And they have measured the timing in which time patient is completing 300-meter path and multiply it with the assistive device they have used. If they have used ankle foot orthosis or a cane or a tripod cane or a quadruped cane, ankle foot orthosis and cane, ankle foot orthosis and quadruped cane. So they have multiplied from 1 to 6 respectively. So if we see here, they are measuring walking ability in real life. Ultimately, they are measuring patients' gait speed, but in the real community, not in the clinical environment. The next thing they have measured is walking ability questionnaire. In this questionnaire, there are total 19 items, in which 8 items are of indoor setting and 11 items of an outdoor setting. And for each activity, they have the score from 0 to 4. And on the depending upon the dependency they are having, they are not able to walk, they are doing that activity with use of wheelchair, dependent walking, supervised walking, or an independent walking. And lastly, they have measured the balance confidence. In this scale, there are total 16 items, in which some of few of there are for indoors, few of them are outdoors. They are asking patient how much they are confident in doing these activities without fall, and patient has to score for each activity from 0 to 100. Okay. Now, for the data analysis for within group comparison, they have used the paired t-test, and for between group comparison, they have used independent t-test. But we will not go into the statistical analysis of this paired t-test, because they give the result in the p-value, which suggests the significance level, which suggests that whatever result you are getting, is it because of the by chance, or it is because of treatment you are giving. Suppose will you give any treatment which is because of the treatment, change is because of the treatment, but there is a little change by giving the treatment. I will explain this in the results. The results is this is the demographic details. Here we will look that were the both group were similar in their demographic characteristic or not. And in this study, we could say that both the groups were almost similar in their demographic characteristic. First, we will see the results of the gait speed. whenever you look any article, you read any article, in the result section there are the tables of the result, which is very confusing because they have given all the values of pre-test score, post-test scores, change values. Then they have reported the T scores, and they have reported the significant scores and all those things. For the patient, the only thing which is matter for the patient is if you are giving treatment or you are not giving treatment, what change they will have in their scores. So you will, whenever you read any article, you look for the mean difference if between two groups. So in uh, in the gate speed here, there is the difference of 0.14 meter per second between two groups at the end of the treatment. So the question is that what 0.14 meter per second this value is indicating. This value is indicating that if you are giving treatment or not giving treatment, there will be the difference of 0.14 meter per second in patient's gait speed. Now the question is that is this value is important for patient, or is it not important for the patient? So we could take the reference from the MCID value. MCID is just an minimal clinically important difference. Uh, for the gait speed, the value is 0.16. I will explain the MCID by giving the example of this score only, that if the patient is having change of 0.16 meter per second in their gait speed, they are reporting that yes, I am somewhat better in my walking. So MCID is reported by the patient, which score is important, which score is making difference in patient's life. Okay. So in this research, there is a difference of 0.4 meter per second, which is beyond, which is lower than the MCID value. So we could say that the difference between two groups, if you are giving treatment or not giving treatment, there is not important differences coming in patient's gait speed. Next thing is the endurance. In the for the endurance, there is a difference of 43 meters between two groups. Here, I would like to introduce one terminology, which is the MDC. MDC is a minimal detective range. It is the error score. Uh, I would like to give an example that whenever we are measuring any outcome, or whenever we are taking any outcome measure, there is some measurement error. If I am taking an outcome in same patient on two different occasions, the score will differ. And if two therapists are measuring any outcome in same patient on same occasion, but there will be some difference between scores of them. So it is because of the measurement error, and MDC score is suggesting that error. For the 6-minute, the established MDC is 36 meter. That if your research score is beyond the MDC, then and then only you can say that there is an actual change. If the change is lower than the MDC, it is just because of the error, not because there is a change in actual patient's ability. So here for the endurance, the difference is beyond MDC and also beyond for MCID. For a 6-minute walk test, the MCID score is 34 meters. So we could say that if you are giving treatment, there is somewhat important differences coming in patient's endurance. Next is the balance confidence. Balance confidence, the difference between two groups is 14 point. For this case, the MDC or MCID value is not being reported. So we will look for the patient perspective, that remember this, for the scale, the score was ranging from 0 to 100. Uh, when you look at the table, if you are 54% confident that they are able to do all this activity without fall, and if they are not giving treatment, they are 53% confident in doing all this activity. Thus, this difference is important for patient? Is it making important difference in patient's life? I would say no. In a scale of 0 to 100, 1 difference is a big difference. The next is they have measured the community walk test. For this test, there is a difference of 10 minutes. 10 point, we could say as a 10 minute. Remember this test, they have measured the time patient is taking for completing 300-meter path and multiply it by the assistive device they have used. So for this test, it is not very well studied in literature. So we does not have MCID or MDC value, and also we do not have any normative value. So we will look that 10-minute difference of completing 300-meter path, is it important for patient or not? Here also I would say this, that the 10-minute difference is not very big difference if you are giving treatment or you are not giving treatment. The next they have measured is walking ability questionnaire. In this, for this questionnaire, there is a difference of only 3 points. There were 19 items. For each item, there was score of 0 to 4, and the difference between two group is 3 points. We could say here that in one of the activity, there would be difference of 3 point, or in 3 activities there will be difference of only 1 point. If you are giving treatment or not giving, there is no much big difference is coming in the results. So what I was explaining in the data analysis, that whenever you are reading any article, you will the researcher is going to report the significance level, that yes, the difference is coming which is significant, but you have to look from the patient's perspective, that is this difference is making any important change in patient's life or not, which we have seen here. So the author have concluded on the basis of the significance level, and on the basis of within group comparison and between group comparison on all those things, and they have concluded that community based ambulation training can be helpful in improving walking ability of patients with post-stroke hemiparesis, and maybe it could be used and adjunct to routine rehabilitation therapy. The limitation of this study was that the study had the small sample size. The second thing is that absence of a long-term follow-up. They have given the treatment, they have measured their outcomes, but whatever change is coming, is it sustaining in patient's life for long term or not? They are missing those follow-ups. The next thing is the benefit of additional treatment rather than specific treatment cannot be entirely ruled out. This is very important thing. What was the objective of this study is to find the effectiveness of community-based ambulation training. And what they have done in their study, they have given the additional treatment to the routine physiotherapy. Means whatever result we are getting in the experimental group, it is because of the routine physiotherapy plus the community-based ambulation training. So they are missing they are missing in their objective. They are failing to they failed in giving the effectiveness of community-based ambulation training. The next thing is the outcome measure do not reflect patients' actual community ambulation. The objective of the study was to measure, they were expecting that by giving the community-based ambulation training, patients' community ambulation will improve. But at the end, what they have measured, they have measured the gait parameters. They have measured the gait speed, endurance, patient's confidence, and all those things. None of the outcome measures were purely measuring patient's community ambulation. There were few scales like walking ability questionnaire, but in that also there were few activities of indoor and few activities of outdoor. So there were no any particular outcome they have measured which could reflect patient's community ambulation. So this is a very major limitation of this study, we could say here. Other okay. Now most of the critics we have gone through, but just to summarize, in this study, the patient's allocation was blinded and randomly. So there was no selection bias in this study. The assessor was blinded, so there was no chances of detection bias. The therapist and patient were not blinded, so there could be chance of performance bias. But in physiotherapy researches, the performance bias is that thing that we could not avoid, that we could not blind the patient or we could not blind the therapist. So it is okay to have performance bias, but there are other biases in this study, such as there were dropout and in the study, and they did not reach to the final conclusion. So there are chances of attrition bias in this study. And in the start of the trial, the groups were not similar. When we look at the graph here in the walking ability questionnaire, the blue is indicating the pre-treatment score and red is indicating the post-treatment score. The uppermost is the control group and the lower is the experimental group. Here you can see this, the score between the before the treatment was given, the groups were not similar. This could make and this could impact our result. For the activity specific balance confidence, for the 6-minute walk test, for the 10-meter walk test, in all those outcomes, patients were not similar before starting the trial. That was also the limitation of the study. Now the next term I would like to introduce is the treatment effect. Treatment effect is simply quantifying the effect of the treatment by giving the value which suggests how much treatment is effective. Was the treatment has the large effect size or the small effect size? And the score ranges from 0 to 1, and near the score to the 1, it indicates the treatment is having large effect size. And for the treatment effect size, you could simply calculate this by searching in the treatment effect calculator in the Google, and you have to just put all the values of the experimental group and the control group, and the calculator will give you the scores. And for this research, for the gait speed, there was the large effect. For the endurance and the balance confidence, the effect size was medium. And for community walk test and walking ability, the effect size was small. The next thing you will look in the research is confidence interval or a precision. Confidence interval is simply if I explain in simple words, if you give this treatment which is given in the research in your participant, which have the similar characteristic of the research participant characteristic, you will 95% get the results in this range. For example, if you give this treatment which is given in this research in your patient, there will be the change of a gait speed in your patient between 0.13 to between 0.28. So the interpretation of confidence interval is narrow the range, precise the treatment, and wider the range. You could say the treatment effect is not precise. Here in this article, most of the range is in a narrow range except for the endurance. So we could say here that estimate of the treatment is precise in this research. Presenter conclusion: when we start this critiquing the article, we had one question. The question was, does the goal-directed ambulation training is better than routine physiotherapy in improving patients' community ambulation status? After reviewing this article, we cannot come to the conclusion that community-based ambulation training is better than routine physiotherapy treatment. Why? Because first thing, that they are in their results, they have given routine physiotherapy plus this community-based ambulation training. So result, whatever we are getting, it is an addition to the routine physiotherapy. So we could not come to the conclusion that this treatment is better than routine physiotherapy. And second thing, they haven't measured any outcome which is measuring patient's community ambulation. So we could not come to the conclusion that after giving the community-based ambulation training, patient's community ambulation will improve or not. And the other thing is that if we look from the theoretical basis, this goal-directed walking training in real-life environment is having a strong theoretical basis. But we need an high-quality evidence, and also we need an valid tool to measure the community ambulation ability. So thank you, and you can ask questions.
Okay. Thank you very much, Nidhi. I think it's a wonderful presentation, and also many of the technical aspects such as outcome measure and results and confidence interval you have explained in a more simpler words. I hope that our audience were able to gather it, and I'm aware that there are some issues with audio and so on. So if you missed out something, you can ask her; she will respond. Or if you're having any questions or comments or anything, you can ask now. Please unmute your mic and ask questions or clarifications that you need.
Hello.
Yes, Shay.
Yeah, it's a wonderful presentation, Nidhi. It's a very good presentation. We had seen so many journal clips, but the best thing is you had done it very precisely, and congratulations for that. And can you please explain me the difference between why you had mentioned about MDC for one and MICD for one, and
Okay.
what's the difference? And it's can you describe us between that, please?
Yes, sure. For the Gait speed, only the MCID value is being reported in the literature. And for the endurance, both MDC and MCID is being reported. And I have mentioned that for endurance, the MDC for 6-minute walk test is 36 meter and MCID is 34 4 meter. So
I would like to know the difference between in terms of interpretation. Yeah,
yes,
what does MDC signifies and what does MCID signifies, and what I have to interpret from a clinical perspective.
okay. MDC is just a error. Whatever we are measuring, there could be an error in the measurement process. So MDC is indicating the error process, and MCID is from the patient's perspective that this much difference if they are getting in their scores. It means they are having actual difference in they are feeling actual difference in their life. Are you getting the point that
Can you,
difference between MCI?
am I right to understand that MDC means whatever change we are getting is above the error value, but it doesn't need not to be of clinical importance to the patient.
Yes,
Whereas
yes, yes,
MCID value most probably will give us a value which will be of clinical significance to the patient, right?
yes, right, right.
Yeah, yeah. I think I will give a chance to other people also, and then if then I will come back. Thank you.
Hello, good morning.
Yes. Yes. Solong.
Hello.
Hello. Ariam sir.
Hello.
Hello.
Yes.
Yes, Saranan, go on.
Sir, no, I just want to know because it's a pilot trial. I want to know whether it's been done at a larger scale or it's the pilot scale.
Uh,
I mean,
no, it is a pilot trial, and for this kind of study, there are only 5 studies has been done for the community ambulation, and 2 of the study was that virtual reality and motor imaginary technique. In 3 studies, they have taken patient into the real community, but no,
No,
this
is there
wasn't done
recruitment
on the
going
large
on?
scale.
No, the larger scale, have they started recruitment going on, or they didn't start at all?
In my knowledge, there are not any studies on the larger scale.
No, from the same author I'm asking. Because it's a pilot study, they must have done it to start a study at large scale from the same author.
In my knowledge, they are not doing it.
Saranan,
So,
the study is actually, it's an old study in 2010 or
Pardon, 11 years.
yes. So even the recent systematic review, Cochrane review published in 2015, even in that there was no, from the same authors, there was no such study. So we only assume that they have not conducted a full-fledged study.
Oh.
I think even Koreans follow our trend of putting it as kind of randomized trial whenever the sample size is less.
Yeah, I believe so. Anybody else would like to? Yes.
There's a question in the chat.
Oh, is it?
Do you want to read? Could you please elaborate CASP critic?
Yes.
Okay. Yes, every critic is like in that there are 11 questions, but I have not mentioned the question in the format of question and answer. I have just summarized the critic part. That in that the question is like is the treatment is precise or not? Is that what is the effect size for this treatment? Was the this this research is addressing any focus issue or not? This kind of and at the end, it is used for the discussion part.
Sorry, it's difficult to hear you. Can you just close your video? It will be slightly better if you close your video.
Hello.
Yeah.
Am I audible?
Yeah.
So the CASP critic is mainly used for the discussion, but I haven't in that there are total 11 questions, but I haven't presented in the format of questioning and answering. I have presented by summarizing the critic part because in the while we were going through the article, we have mostly come to the critic also. Going parallel with the critic part also. So in that there are CASP critic, there are total 11 questions, which is asking that did they have addressed the focused issue or not? Were there was randomization was concealed or not? What is the effect, treatment effect? What was is the treatment research was result was precise or not? All those questions are there in the CASP critic. So here I have mentioned in by summarizing the critic part. It is mainly used for the discussion.
Yeah, I think I also want to ask a question. What is the duration of the intervention?
Total 4 week.
No. Sorry. Each day, each session. How long was the intervention?
For the control group, the session was 1 hour, and for the experimental group, they have given 1 hour of routine treatment and 1 hour of this community-based ambulation screening.
Okay. Thank you.
Anybody else would like to comment or ask questions?
Sorry, 1 minute. So did the endurance also increase in the? There was a small change between the control group and the experimental group, right?
Right.
Yeah. Okay. Go ahead, sir.
No, I just want to know like, what kind of environment they had the community training, like more of urban, semi-urban. Will that make any difference in the outcome?
Their study was in the urban setting. Patients were from the urban city, so they have taken patient in their community only, surrounding the hospital, surrounding their pavement, and into the shopping center. That if the population is from urban, rural, so the community-based ambulation could be given into the their community, but here they have given into the urban setting.
In your knowledge, you have any other study done in any other setting? You know? Did it make any difference in the outcome?
No.
Oh,
Sorry, did they have the baseline? They were all non-community ambulators, or did they have any classification at that baseline?
No, they haven't used any classification before the treatment also, and not in the after giving treatment also. They have just mentioned that patients who are having less than 0.7 meter per second speed, they are unsafe for the community ambulation, so they have included those patients. They
So
have
we don't know
used
whether
that
they.
criteria. Yes.
So we don't know whether they already were community ambulators or something like that.
Yes, we don't.
I think they have used this Gait speed-based
Surrogate.
classification system, surrogate. That is again the issue. FAC would have tell us very clearly what the baseline status
No,
is, but
yeah,
they did
the
not.
baseline there is very unclear,
They
right?
did not report.
Mm.
Yeah.
After around 1.5 hours of treatment, they didn't have any much of increase in the speed.
No, only there was the difference of 0.14 between two groups.
Can I ask you a theoretical question, not to do with the
Yeah, sure.
why do you think that they didn't get any change? Or why the treatment did not work that much?
In my perspective, they have measured the gait parameters. So, gait parameters
No,
after.
no, we can't assume things which the data is there, so we can't say that there is no data, so I don't know. But within this these data, do you have any hypothetical assumption why there was no difference in gait
the
speed and?
targeted the targeted treatment was improving community ambulation. If you are giving any treatment to improve community ambulation and you are measuring gait speed, so there would not be any difference in gait speed or in patient's endurance. If you are targeting patient's gait speed, work for improving gait speed, then and then only patient's gait speed will improve.
Nidhi, the question is, as you have stated, theoretically, we expect that a community ambulation based training will improve their community ambulation ability, right? Theoretically, we
Right,
have,
right.
right? But in this study, the result shows that it did not improve their community ambulation ability, okay, as you have stated also. Now, the question is, can you think of why
Right,
this did not happen, even though theoretically they should have improved?
because
Hypothesis
there is
wise,
some correlation, I suppose, between the gait speed and community ambulation. It cannot be a perfect measurement, but there should be some changes, right?
Right, sir.
if you can think of, you can tell, otherwise that's okay.
Yeah, that's all right.
Yes, sir.
Any audience could chip in, and
Yeah, exactly.
that also could be better, because yeah.
Probably if they're already plateaued in the gait speed, so because we know that for every human movement there is a plateauing of velocity. So if they've already reached that, I'm not sure if we can expect any improvement on that parameter.
I think that's a good hypothesis.
And the community ambulation ability is expected to improve, even if there is not much changes in it. but their ability to walk in the community is expected to improve, but that did not change.
I think even the duration can be one of the thing where we can with even more we would have expected, because the as per if you are concluding that there was no effect because the MCID is MIDC is 0.16 and we have got 0.14, and I think it is very minimal to comment just because of that 0.02. Even with more training, maybe they would have improved.
But that seems to be a very, very small change. So I'm not very sure how the dosage alone will give a sort of a quantum link into it. I'm just asking you this is because if you are trying to do a extrapolate from this and try to do a beyond the pilot, if you're trying to do a study, what are the factors we want to change? That's what I'm trying to ask you, Nidhi. If you don't know, that's all right. If you don't have any comment also, it's all right. I just want to have it as a discussion because the study shows that it has very little value, I suppose, other than the endurance, because that is because they did
So will
1.5
there
hours.
be any effect of the fatigue the patient
Sorry, I couldn't get you.
experiencing?
Your audio is lagging.
Sorry, I couldn't get you.
Can you ask again?
So will there be any fatigue because it is a 2-hour session the patient is experiencing? Will there be an effect because of that?
Sorry, I still couldn't
I
hear you.
assume she has said because of fatigue that they have had, like with
Okay.
2 hours of treatment. I assume so. I don't know.
Yeah. Hari Om,
Yeah.
this is Shiv Kumar.
Yeah.
Yeah. I have, I'm just looking at the measures. One measure is for looks like a velocity, and another is time, and one is for meters. Is there any justification why they have really chosen these measures? What exactly they wanted to look in for? Or they have just chosen the array of measures putting together, and we are looking at different dimensions in a different way. But probably, I think there must be a real reason why they have chosen these things and what is that they really wanted to measure. If we could understand that.
So can I
I
ask
think
Nidhi to respond
Nidhi
first?
too. Yeah.
Yes, they have used the gait speed and the endurance because there are lots of literature available which are saying that for community ambulation you must have this much gait speed. For the community ambulation you must be able to walk 300 meter. And all those criteria were given in the literature that by correlation studies and all those things. So that's why they have give and activity specific balance confidence because is also in the literature is suggesting that it has the high correlation with the community ambulation. So that's why they have used this.
I think that's a fair point. I think because a common surrogate, a lot of people you do use is gait speed. I think after Jacqueline Perry. Correct, Prakash?
Yes, sir.
Can I? Sorry, Shiva. Do you want to add more to it, or?
No, not exactly. I just chipped in to find out that because too many measures, adding too many measures may not really make sense. But, there must be a reason because I was going through the methodology, but I couldn't find any particular reason why they have added each of them. So there must be some reason so that we can find out whether that reasons are justified when we come out further. But that was not found in the methodology as such. They have just said they are using these measures. So
in this article, they haven't given the reason for choosing this article. They are saying that these articles are having high test retest reliability and these measures are sensitive to change, and all those reasons are given in the article. But choosing this article, the reason behind that is that these outcomes are being used in the literature for means as Harigam sir said, there's as an surrogate outcome.
Yeah. And one more thing I wanted to add about is this MCID and MDC. We are looking at only the the difference, that is the standard deviation and the mean. Probably when we put a 95% confidence interval, some of the values might fall even beyond MCID. So we can say few people would have crossed MCID, even
No,
if the other end of.
No, she said the confidence interval is very narrow, isn't it, Nidhi?
Yeah, but better because I did that work to find out the 95% confidence interval. So if say for 0.21 plus or minus 1.2, if we put a 95 confidence interval, then we might know whether is there anybody. Most of the groups did not fall under the cross the MCID value, or at least few of them crossed. So probably we might even extrapolate some of our results for some reasons. We can say that it is absolutely not a useless study. We can say
But
some people might.
But isn't it because it's a extremely small sample size that's difficult to?
Maybe that is also one thing.
Sorry, Nidhi, can I ask you more?
Yes, sure.
Because I'm assuming you're doing something in the community ambulation. What's the difference between community ambulation training and normal gait training? What parameters do you think should be different?
Whenever you treat any patient in routine physiotherapy that we are treating inside the clinic, you are not exposing patient with the environmental challenges which they have to face when they go out.
Right. So what is the parameter? What is the parameter which is different between inside the clinic and outside the clinic?
When you treat patient inside the clinic, you are treating patient's gait speed, patient gait pattern, and you could walk on an endurance and all those things. But when you make patient walk in the real community, you are exposing patient to the environment.
No. I understand. I'm asking in terms of parameters or variables, because if we know the variable, then we can come to the answer again.
Dimensions of environment.
Dimensions, right.
Yeah. Patient, the variables such as the negotiating an obstacle, then adapting to an uneven surface, means overcoming this ambient demand, terrain demand, then postural transition, and physical motor dual task, cognitive dual task. All these variables we are targeting when we do this kind of treatment.
Right. So that's what I wanted to ask. So if there is so much of variability, how far was the variability in the intervention they have given?
In this study, they have tried to give they have included many variables, because they have taken patient into the shopping center, so they have to do all those motor dual tasks, cognitive dual tasks, postural changes, and they have taken patient into on the staircase, and negotiating curves, pushing load. All these things were aided in this treatment. Measure variables they started.
Right. Yeah. Okay. So even after that, it doesn't have to have much of effect, right?
Yes, sir.
That is, even after taking them to the, they seem to have done it theoretically very well in terms of the variability of the environment. So what are they missing? Just coming to that again and again.
Unless you give the answer, you're not going
to. I'm just wondering what do you think is missing in this?
I am also thinking right now that, but
we will have another. We will
think
about it. If you want to discuss again, I'll schedule another meeting.
Sorry, somebody was wanting to speak.
Vignesh, yes. Okay.
Okay.
Yeah. Yes, please go on.
I'm Sam.
Yes. Yes. Yes.
Yeah.
Yes.
I feel the results may be due to multiple factors, right? Starting from sample size to dose intensity. But what we need to take from this article is the trend, the promise that uh, task-based training in community is promising, if not proven in this study. So many factors could be playing to show that there's no effect. And another point on the outcome measures, I feel the outcome measures are reasonable. One is having speed, endurance, and confidence. These are the ones that typically tend to improve in chronic strokes than looking at kinetics and kinematics. Thank you.
Okay. Yeah.
I think because of the power of the article, the power of the sample size may also have probably not given us a clearer view.
I think the major problem with this RCT, like it is with many other RCTs, is that they have went into a very reductionist mode when they want to develop a rehabilitation program. Say, for example, the first question: how many of the patients in the experimental group actually wanted to go out? Right? We know that clinically we see some want to go out, some doesn't want to go out. So that itself is a question. And how many of them were encouraged? So one of the major reason people want to go out but don't want to go out. Clinically, we all know that the fear of fall is there. They all are worried about going. So how much of reassurance that they were given? There are so many components of treatment that is missing. And there is a number of factors. And also in one group, they're receiving Bobath, which is sort of opposite to a community. The theoretical assumptions are very different from Bobath and community ambulation, where you will make the people focus on their quality of movement more.
Yeah.
Yeah, and the community ambulation, which is added, it's sort of something different, where the outcome is more important. The goal is more important than the quality of movement that is used. So quite a few issues. And another, if you go into the outcome, now the entire paradigm with clinical trial is towards patient reported outcome measures. That should be the primary outcome. And as we know, even the community ambulation questionnaire which they have used, it is not exactly a patient reported measure. It has I mean it was not developed.
Sorry, can you send that to us so that we can have a look at it? Is it possible, Nidhi?
Yes,
the scale.
Yes.
Yeah, thank you.
Yes.
Right. So quite a few issues. So again, the conclusion, we can't just, this is again another important reason why we have to take general club, is that we can't take a conclusion and say that it is effective or not effective, even when the study result shows like that, because with one study we will never know, and there are quite a few things that we need to look into. And as a clinician, we got to slowly learn to take one thing at a time, and whether what's an MDC, how to use it to interpret, and slowly from a clinician perspective, we got to get used to how studies are done, what all the possible reasons might be there. Anybody else? Vignesh, yes?
Yes, sir.
Yes.
Sir, I wonder what was the instruction given to the patient on a daily basis. Like she told the duration was 1 hour. Whether the patient was told like you have to walk for 1 hour, or it is like whether any like local target, like in 1 hour you have to achieve this distance, or in this intensity you have to continue for this duration. Or, I wonder what was the instruction, like whether it is based on daily goal, like progression is based on what variable, whether it is the distance covered, like improving the distance covered in 1 hour, what it will be like.
Yes.
I wonder.
Yes.
Yes. They haven't mentioned the specific in that what instruction they have given in this article, but and also the criteria for progression also not mentioned in this article. They have just said that they have given this in the first week, this much in second week, this much in the third week. So
Okay, okay. Maybe determining or taking a variable for like seeing the progression and to enhance their capacity or making a demand makes like it will be individualistic to each patient, so that dose will be tailored.
yes.
Yeah.
And one more thing that in the their method section, they have reported that 5 of the patient in the 4 week were not able to were not progress to the 4th week his dosage because they were the reason they have not given in that they have only said that they didn't make into the 4th week.
Okay, okay, okay. Thank you.
This is one common problem in RCT where they don't give us enough information, especially with dosage and so on. Ariam sir, do you want to put on, because we published a study pointing out this problem, you want to throw some light on information on reporting issues?
Okay, so we just want to know 2 or 3 things. One is, say for example, uh, we want to know who gave them the treatment, because I think if it is Bobat in the other group, we really want to know whether those people knew what is Bobat and also that kind of information. And
Sir,
we also, sorry.
yes, that was also not mentioned that you have given the treatment.
Right. The other thing also, I think one thing that is very good here is they have given you the setting, I suppose, here. That is, they actually took the patient to a shopping mall or outdoors and they have told us that properly. So that is also vital if you are giving a treatment like this, where the treatment was given. And the 2 things which we are missing here, I think, is say for example, you can't say 1 hour of walking exercise because nobody walks for 1 hour. How much of time was there for rest? How much of it was actual practice? Especially in neurology, we know that a distributed practice is always better. So after, in 1 hour, probably if they had walking exercise for 25 to 30 minutes, that would have been super. And another 30 minutes, they should have had some sort of rest. So again, that again is the dosage part of it is vital. And as Vignesh also has pointed out, I think the instructions are missing, especially if it is task oriented. If there is no goal, I'm not sure whether it is inside the principles of task oriented itself. So I think that is also missing. And we also don't know whether it was done 6 days a week, 5 days a week, 7 days a week. Do we know, Nidhi?
Yes, sir. It was 3 times per week.
Right. So we don't know whether it was alternate days or 2 days, then 2 days rest or something like that, right?
Yeah.
Right. So they are actually nowadays saying that you have to explicitly say that it was every alternate day and Saturday, Sunday we had a holiday. That kind of thing has to be there. Because if you have 2 days of holidays, the endurance may not be that much of, it may not be increasing that well. So I think these are the things which we need to, in a simple terms, what is missing. And you will see that it's not just in neuro, from cardio to low back pain, all RCTs miss these things. So if you're trying to do an RCTs, please write all these things. Thank you.
Yes, Sheikh, you were having some questions you want to ask later. Do you want to ask?
Yeah, sir. I just want to ask this from the statistical point of view. They had whether a normality test has been done or whether it is necessary, or there are, I think there were 2 questionnaires which comes under this ordinal scale with the data which is to be ordinal, and however they had used the say, our usual median and mean and SD things. Parametric tests. In short, for a non-parametric data, they had used parametric tests, and the same has been interpreted. Whether is it of any concern?
No, sir. They have mentioned in the data analysis that they have used this independent t-test and pair t-test. So we have to assume that the data was normally distributed.
Okay. Then what about these two questionnaires, which is data itself is non-parametric, na?
Yeah.
No, what I am asking is whether is it of any concern to our interpretation? That's what I am asking.
I don't think so, because what we are looking here is the what change between two groups we are having. If we are going by the statistical that it is significant result or not, then it might is our concern. Normal distribution.
Okay, everyone. I think this is a wonderful discussion that we have had, and I'm thank Ms. Nidhi for presenting today and giving a very clear explanations for the article that she presented. I'll be very happy even if you don't have comments, share. If you don't have questions, please share your comments and how you felt. I hope it was useful for most of you. And please join us in our next meeting 2 weeks later. We are having two young researchers who have just completed their study. They will be sharing about their research. Both of them done research in the same area, which is swimming. That is how the results can be knowingly or unknowingly, distorted in randomized control trials, problems in published research. So we will be discussing with them. So join us after 2 weeks on Sunday, same time. And thank you very much for joining today. Thank you.
Oh, wonderful, Miss Nidhi. Bye-bye.
Thank you, sir.